Hi, Valeria.
Hello.
All right. Well, I guess it's just you and I today. All right. So today we're going to be going over Chapter 17, Therapeutic Procedure. This pertains to the portion of neuromuscular in our curriculum. And I want to start with the learning objectives. So after you have mastered this chapter, you will be able to describe the 4 parts of the therapeutic procedure, demonstrate a client intake procedure for therapeutic massage session, list the at least 4 common assessment protocols, perform posture assessment, demonstrate assessment by passive, active, and resistive movement, identify soft tissue barriers, palpate and differentiate tissue layers and textures, differentiate between chronic and acute soft tissue condition, explain how assessment, explain how assessment findings are used to develop session strategies, determine performance strategies that are specific to a client's needs, demonstrate how to identify and release constrictions in hypertonic tissue, explain the appropriate therapy in the initial stage of an acute soft injury, and explain the importance of evaluation. So this is part of a skill set that you will use on a day-to-day basis because you need to be able to distinguish different types of tissues so you know how to plan the massage and execute the massage. So why study therapeutic procedures? Students of therapeutic massage should study and understand therapeutic procedures because of the following. Therapeutic procedures provide a blueprint for practitioners to assess, plan, treat, and evaluate clients seeking relief from physical conditions and dysfunction. A thorough assessment provides a basis to understand a client's condition or change in their condition when they come for massage. It also is the basis for choosing techniques to address specific concerns. Creating a treatment plan provides guidelines and helps clients understand goals of each treatment session. And evaluating the outcome of the session helps improve the treatment strategy for current and for future clients. All right, so introduction. Describe the 4 parts of therapeutic procedure. Therapeutic modalities and classical massage techniques learned in earlier chapters can be combined in many ways to fit the needs and desires of the client. People seeking relief from painful conditions and recovering from injury are better suited for more specific treatment regimes. Therapists can choose from an endless number of possible routines of full body massage or massage that can focus on a particular body area according to the client's request. So no 2 massages performed, even if it's by the same therapist on the same client, will be alike, right? Every time you come in contact with those tissues, you will analyze, assess, plan, and execute what is going to happen to those tissues. Becoming competent in more sophisticated therapeutic applications requires ongoing training, practice, and expertise on the part of the therapist. You should be able to determine through assessment where and what soft tissue components or body functions are involved, and then provide appropriate therapeutic interventions. Chapter 17 introduces therapeutic methodology to identify more specifically the top soft tissue conditions that respond to therapeutic soft tissue interventions. Therapeutic procedure includes acquiring a concise medical history, using assessment procedures to determine constricted and painful conditions, developing treatment plans, performing appropriate treatment practices to address the conditions more specifically, and then evaluating the results. Overall, therapeutic procedure is more advanced massage therapy session that incorporates more sophisticated treatment goals focused on reaching specific results, right? So we have a goal in mind and a way to reach them. So I want you to highlight here, therapeutic procedure involves 4 basic steps. Number 1, assessment. Number 2, planning. Number 3, performance. And number 4, evaluation. Right? And highlight. Assessment involves reviewing any information available at the onset of the process to understand the present condition. During the planning stage, the information gained from the assessment is used to set treatment goals, determine strategies, and select therapeutic techniques to address specific conditions found during the assessment. The performance is the application of the selected techniques. And go ahead and highlight here. The evaluation examines the outcome of the session regarding the effectiveness of the selected procedure for the condition. So in the planning stage, we're going to procure our information. We're going to define the goals, determine our strategies, and then choose what techniques we're going to use. In the performance stage, we're going to use said techniques and go through our plan. And then finally, in evaluation, we're going to examine what happened when we use these techniques. Did they work? Did they help us improve range of motion, or did they not help us improve range of motion, as an example? Documentation of therapeutic procedure. All information must be carefully documented in the client's files. Subjective, objective, assessment, and plan, or SOAP charts, are well suited for gathering information gained in each segment of the therapeutic procedure. Go ahead and highlight that whole sentence. Now, SOAP notes were talked about more in depthly in chapter 9. If you need to review them, that's where you'll find it. So, therapeutic process. In the therapeutic procedure can be implemented in many ways in massage therapy sessions. The process is valuable for long-range goal setting, short-range planning, and during actual massage session. Highlight here. In long-range goal setting, the assessment might be extensive and planning could encompass several sessions, 6 to 10 sessions, like their example. All right, and highlight. After the treatment strategy has been formulated and discussed and treatments given, an evaluation is performed to determine the progress that has been made and what further therapy is needed. Short-range planning can involve a single session. In this case, the assessment process might not be as extensive, but it can focus on a more specific complaint. The client's needs are considered, indications and contraindications are determined, and a treatment strategy is chosen. The session is performed, and at the conclusion, the outcome is evaluated as to the effectiveness of the session. During the application of therapeutic massage, the therapeutic procedure is constantly applied. As the therapist proceeds through the massage, the hands continually assess the condition of the tissues, the quality of and the constrictions of the tissues, the movement of limbs, the physical and verbal responses from the client as different massage movements are being performed, continuously provide information that the therapist uses to plan the next move. So you're constantly taking in information, feeling the tissue, analyzing what's happening, and then choosing how to proceed from there. The evaluation process is also continuous as the therapist monitors feedback from the client about effectiveness of selected movements throughout the treatment. The therapist continually makes adjustments through sensing changes in the muscle structures being addressed and that are noted from palpation and client communication. So demonstrate a client intake procedure for therapeutic massage. Review the preliminary client consultation or intake discussed in chapter 9. So chapter 9 was our documentation chapter. The preliminary intake for therapeutic massage contains the same elements as discussed earlier, but more extensive assessment techniques and planning strategies are included to better determine which services can be addressed and the particular concerns of the client. So we're going even further in our questionnaire to figure out exactly what we can use. The extent of the intake process depends on the purpose of the client visit and the intent of the massage treatment. The intake process begins when the client calls or makes an appointment and continues until there's an agreement between the client and the therapist to proceed. and the massage treatment commences. The intake involves an exchange of information to determine the best course of action for the therapeutic relationship. Client intake includes several segments that can vary according to the individual situation. Some segments include the following: setting the appointment. This might include an initial screening to determine the primary reason for the client visit and whether the practitioner's services match the client's needs. Initial greeting and consultation. Extra time can be scheduled for the first consultation to fill out intake forms and exchange information, such as reasons for the visit, policies, and procedures. That's always a good idea to book out more time, especially if it is someone's first time. It may be their first time just with you and have had massage before, or their first time getting massage, period. So you want to take time to be able to explain things to them, show them around, show them the bathroom, because inevitably they're going to have to pee. But to make sure that they have an understanding of how the session is going to proceed. And go ahead and highlight here, assessment. The assessment consists of the client interview, health history, observation, palpation, and special tests such as range of motion, right? So it's not a bad idea if they're coming in and they're saying, you know, X, Y, and Z is happening, and you, before they're even on the table, you know, show me, you know, any restriction in your movement. And, oh, I can only get here, but turning to their right side may be completely fine. Okay, do you feel the congestion as you tilt your head to your ear? No, I don't feel anything this way. What about putting your chin to your chest? And, oh, yes, I'm feeling that there. Right, and so we can start to analyze as they're going through their range of motion, what musculature is being activated and where we're going to need to focus our intentions. The treatment plan, when the relevant information has been collected during the assessment, client and therapist can determine a plan for the session or a number of sessions. Informed consent. After the therapist and the client discuss the assessment findings and agree on a treatment plan, the client gives informed consent as the session commences. All right, so we need to educate them in their treatment session as well. We need to tell them what and why, right? Identify and practice assessment techniques. The successful practice of the therapeutic massage depends on an accurate and thorough assessment. The therapist must understand as much as possible about the client and the condition to determine which massage procedures to perform or whether to refer the client to another health professional. If you are in doubt, you know that it's going out of your scope, don't be afraid, you know, that you're going to lose them as a client. They'll actually respect you more if you say, listen, what you're explaining to me sounds like it's out of my scope. I'd like you to, you know, see your physician first before we can proceed. Protect yourself in that way. The extent of the examination depends on the intended therapy to be given. If a relaxing massage is the intent of the visit, only enough information needs to be exchanged to determine that there are no contraindications. Informed consent is then obtained, and then the session can commence. Pretty easy. If the intent, let's go ahead and highlight this here. If the intent of the visit is to respond to specific concerns of the client or to address some soft tissue dysfunction, a more extensive assessment can provide information to determine the nature of the dysfunction or pathology and help decide the best course of treatment. Assessment tools. The goal of the assessment is to, as specifically as possible, identify the dysfunctional tissues and, if possible, the conditions that caused the problem. The assessment tools can vary according to the preferred modality. Let's go ahead and highlight this sentence here. A common assessment protocol includes the following: a client medical history. Let's highlight this bulleted area. Close observation, postural assessment, pain assessment, any number of functional or orthopedic assessments, palpation of suspected structures. And on to the next page, 658, client medical history. A concise Client history provides a wealth of background information about social, physiologic, and psychological elements related to the complaint of the client. Client information and medical history forms are filled out on the client's first visit. The client information form can include questions about the client's age, occupation, hobbies, and reasons for seeking the service. So we need to know their age, because as we age, the body deteriorates. So that's going to play a factor in the way that our tissue dysfunction may present itself. Their occupation, do they work outside? Do they have a high impact job, or are they surfing a desk 8 hours a day? Either way, they're going to be in contact with some repetitive activity that could be contributing to their dysfunction. Hobbies, it might not be something that they do at work, but something they do in their free time that's causing whatever dysfunction. Or they could come in and say, X, Y, and Z happened. This is why I'm here. These forms can be designed to provide extensive and vital information about the client's past and current physical condition and the client's expectations and concerns. The medical history form provides information about the client's past medical conditions, including major illnesses, medications, surgical procedures, traumas, and allergies. The form should include contact information for doctors or other healthcare practitioners the client is seeing for any current conditions and a written request for permission to contact those practitioners. The form should also include questions about conditions the client has and the history of those conditions, as well as a diagram of the body so the client can illustrate areas of concern. So we have here 17.1a and 17.1b, a client health history form. Now, these are quite comprehensive, but we need that because we're trying to be as specific as possible as our scope allows. And we see here at the top some basic information: name, address, their date of birth, who referred you, their occupation, some phone numbers, their actual reason for the visit. What would you like to achieve with our work? You know, so that will answer a multitude of questions. Pain relief, relaxation, I'm stressed out, I'm experiencing pain. You know, and a number of things can be written there. Have you seen a doctor or another health practitioner regarding similar conditions, right? You want to know what avenues they have gone through before coming to you. And then they have list their names and phone numbers, and do I have permission to contact them? When did you notice the condition and what started it? Do they have an actual event that caused the condition, or was it a gradual onset of maybe small activities that have led to it over time? What makes it worse? What makes it better? You know, what are you doing at home that, oh, you really notice it flare up? Or what are you doing at home that you finally get some minor relief? Please indicate on the following conditions that apply to you. Mark any current conditions with an X and past conditions with an O. Right, so we want to know if they have or have had, right? So we have an X and an O system there. And we see the multitude listed. And then if anything that isn't listed here, we go ahead and give them a little couple lines to fill in anything that we may not have listed. On the following page, we have infectious and childhood diseases, and we list what and when, congenital or acquired disability, and to describe it, surgeries, list what and when, injuries or accidents causing injury, list any other medical or health condition not listed, list including frequency of use, all medications, remedies, herbs, and supplements you use. Do you use any of the following? List the frequency and the amount. We have caffeine, nicotine, alcohol, sugar, recreational drugs. List stress relieving activities you participate in, include type and frequency, that is exercise, massage, hobbies, sports, etc. List any other concerns or comments regarding your health status or well-being. And my favorite part personally, because most of the time we're getting people who don't have the medical terminology in their vocabulary to explain exactly what is bothering them. So we give them a body diagram, right? And on the diagram, like it says here, indicate any areas in which you experience pain with an X and circle any areas of concern. So they're going to go through with their pen, and maybe they have discomfort in their upper shoulders, but right between their shoulder blades is where they feel actual pain, right? And so we can really hone in on where the problem area lies, right? Instead of just having a body chart and being like, circle what hurts, right? We don't really get a specific answer that way. Then of course we'll have them sign and date it. All right, back down to our paragraph here underneath the chart. I want you to highlight, the client must sign a separate release of medical information form for you to share any personal information with other healthcare professionals. So that will be in addition to this form here. And you will keep it for forever and ever and ever and ever and ever. So if we turn the page, we see an example of a release of medical information form. Includes the same kind of information, client's name, phone, address, state and zip code, that. I hereby authorize, and it would insert your name there, to release any to any physician or healthcare practitioner directly involved in my care, any medical records or other personal health information necessary for the purpose of receiving physician's recommendations and approval, or sharing concerns regarding my health and well-being. The authorization remains valid for a period of blank to blank for the time period that I am seeing the above named practitioner. And then they will sign and date, and that will go in their file. After a client has filled out the intake and medical history forms, the practitioner has reviewed any of the forms, consultation or interview between the client and the practitioner is held to clarify any information on the form and set the intentions for the session. This is the opportunity for the client to clarify their concerns and answer questions the therapist may have, right? So we want to be as crystal clear as possible going forward. We want to know exactly what they're trying to tell us. Right. Gathering information during the interview. Information from the forms combined with the client interview clarify the client's concerns, needs, and expectations. Reviewing the completed forms and questioning the client to clarify any information on the forms. Provide the therapist with preliminary information to decide how to proceed, whether the client should be referred to another health professional, or whether the client's doctor should be contacted before going further. If in doubt, remain on the cautious side. Refer the client to an appropriate healthcare professional for more clarification about questionable conditions. Confer with or work under the supervision of a medical doctor or other therapist in difficult or questionable situations. Rely on your peers and rely on people who have a more intense license than you, like a doctor. Intense isn't the word I want. More thorough licensure. They've been in school longer, they've got a bigger degree than we do. Data from the forms and interview provide information about the nature of the complaint, which body parts are affected, and whether the condition is chronic or acute, and what makes it worse or better. Find out when and how the condition started, what the client has done about it to date, which treatments the client has received and by whom, what has helped, what has made it worse, and so on. Did a specific incident start the condition? Was the onset sudden, or did it come on gradually? What has been the progression of the condition? Where in the body did the client first notice it? Is this the first time the client has had experience with the condition? If not, how often? When was the last time? And when was the first time the client had this condition? Questions should also ascertain how long the condition has persisted, and whether it is constant or intermittent. If it is a painful condition, determine the location of the pain. The client can put a finger or a hand on it. Does it radiate? Has it traveled from its original location? What affects it? What makes it worse? What makes it better? Does the time of day or activity affect it? What is the intensity, duration, and frequency of the pain? Does it come and go? How often does it recur? What instigates its return? Describe the pain. Is it sharp, dull, radiating? Does the pain interfere with daily activities? Is the client using medications for pain? What medications? What effect does the medication have on pain? If the client is using pain medications, discuss how medication might influence the client's ability to give accurate feedback about the comfort of the massage technique. All right. So if they are taking things that inhibit their ability to feel pain, by and large, it's going to inhibit their ability to feel palpation and pressure. So it's going to affect their ability to receive a massage, which would be a contraindication. So I want to pop into Massage Corner 17.1 here at the top of page 661. And we have health history question examples. So we see, what is the client's current overall health condition? What are the current symptoms and how long have they been present? How did the condition start? What has been the progression of the condition? What has the client done about it? Has the client received other treatment? Which types have been, what have the results been? Has it been diagnosed by a doctor? If it is an injury-related condition, then ask the following. When did the injury occur? Can the client describe what was injured? What was done at the time of injury? You know, what did they do for first aid? Oh, I just got up and walked it off. Or no, I was in the hospital. Which types of treatment has the client had for the injury? Which symptoms is the client experiencing currently? Pain, swelling? If it is a painful condition, then ask the following. Where is the pain? Is it localized, radiating, over an extensive area? Describe how and why the pain started. Describe the pain. Is it sharp? Is it dull, throbbing, radiating, constant, intermittent? What makes it worse? What makes it better? Does it affect daily activities? How does it affect those daily activities? Is the client using medication for pain, and which medications? Questions about the tolerance of the condition and what the client has done to cope with correct the problem. Learn about the client and his or her willingness to do something about the condition. Take notes on answers and include them in the client's file for future evaluations. By this time, the therapist knows the client's primary concerns and whether the services can be of benefit. The therapist also has a better idea of further assessments that can involve structures, patterns, or causative factors related to the complaint. Post-interview. After the interview, the intake process can continue with various assessments that include observations or visual assessment, a variety of functional assessments, palpation, and specialized tests to the suspected condition or selected modalities. Information from various assessments is gathered and analyzed to determine the best course of treatment. Both client and therapist discuss the results of the assessment and options for possible interventions or treatment modalities. And a treatment plan or care plan is created and mutually agreed on. The client again provides information, consent by signing the care plan, provides informed consent, by signing the care plan. This marks the end of the intake process and the performance or application portion of the therapeutic procedure begins. I am all tongues today. Oh, I got an Adrian and an Adrian. Can you hear me, Adrian? Okay. There's two of you on my screen, so I was just making sure you were adequately connected. Subjective and objective findings. Information gained during the interview and assessment portion of the session is both subjective and objective in nature. Subjective information is gathered as the client describes his or her personal experience with the situation. The client should answer questions about what the client feels or where it is felt. When did it start? Is it constant or intermittent? What affects it, makes it better, or makes it worse? During various tests, the client can describe the experience or how it feels. Let's go ahead and highlight here. The therapist or another observer receives objective information through observable, observation, palpation, and specialized tests in which findings are quantifiable and usually measurable. All right. Now, pain scale. A subjective pain scale or analog pain scale is a useful tool to assess the relative discomfort a client is experiencing. The client can rate pain while describing the condition and guide the therapist during a therapeutic technique or assess any improvement in the condition following the session. Let's go ahead and highlight here. The pain scale provides the client with the opportunity to describe the discomfort or pain being experienced on a scale from 0 to 10 or 1 to 5, where 0 or 1 is no discomfort and 10 or 5, depending on what rating you're using, is unbearable, excruciating pain. Right, so at the very top of the page, we see the numeric pain rating scale. 0 is no pain, moderate pain is 5, and the worst pain possible is a 10. And then we see a rating scale using facial expressions that can be represent of the client's pain level. So we see the happy little smiley face, no pain whatsoever. We go down 1, it hurts a little bit more, hurts even more, hurts a whole lot, hurts worse. Personally, I like the numbers. They're a little bit more concise to me. The pain scale can be used when a person describes discomfort during a preliminary assessment. The client can be asked to rate the pain when it is worse and when it is at its best and at the present time. If the client is using pain medication, they could rate the pain before and after using medication. At the end of the session, clients can again rate discomfort to help determine if the session's effectiveness. So you can observe before and after, what is your pain level now, right? And then you can observe after, what is your pain level, to see if there was an effective use of modalities. The pain scale is also used to determine appropriate amounts of pressure to use during certain treatment modalities, such as trigger point release or positional release. For instance, when applying pressure to a trigger point, ask the client to rate the discomfort and tell you when you have a rating between 5 and 7. This seems to be the ideal amount of pressure to have the greatest therapeutic value. If the discomfort rises above this level, that is between 8 and 10, the client tenses up and any therapeutic gain plus the trust of the client could be lost. Therapeutic use of the pain scale is discussed more in the trigger point release and position release of release section of chapter 15. So we went over that on Tuesday. So let's continue onward to the next page. Use observation as an assessment tool. Looking at your clients, the way they move and interact with their environment will tell you multitudes of information. Observation plays a major role in the assessment process. Go ahead and highlight here. The observation portion of a client assessment should begin when the client walks in the door and continues until the client leaves. You watch them the whole time. When they're on the table, when they're walking down the hallway, when they're opening the door. And in my head, I kind of gauge my client the way that the Terminator has his little grid and he's watching everything and analyzing, you know, well, their foot moved this way and it looked like they had a little bit of an angle here. And when they step, that leg comes out just a little bit. And you're just consuming all of this information because it's only going to help the client for you to be that observant. The client's body language, that is how the client holds posture, stands, moves, and sits, gives clues to where pain and tension are being held. Observing body language can also give some insight to the client's emotional makeup and self-esteem. Watch for guarded movements that the client used to avoid or mask any pain, right? If they are, I use this example a lot, but if they are, you know, drawn to look at something that's over here and they turn their whole body to look over here instead of, right? That's going to tell me we have some dysfunction going on in our cervical spine, right? Visual observation. Through visible observation, the therapist can assess structural alignment and balance, bilateral discrepancies, and variations in skin color and integrity. Go ahead and highlight this. Look for bilateral symmetry, both structurally and in the way the client moves. End your highlight. Throughout the assessment, it is helpful to compare one side of the body with another. Now, the body is symmetrical, but it is not perfectly symmetrical. So there will be minute discrepancies, but what we're looking for is something that is quite noticeable, that's actually interfering with normal movement. When doing many comparisons, look at the unaffected side first to get an idea of the personal norm for that person. So you're going to gauge their normal first and then assess the dysfunctional, right? Then look at the affected side to assess deviation from that norm. Note, when a person moves, whether one side of the body is held tighter or higher, is the gait or walking balanced and normal? Does the client stand erect or list to one side or stoop? Observations come into play more formally when assessing posture and gait. So posture assessment. Posture assessment is a wonderful tool. Assess posture by observing how a person maintains an upright position in relation to gravitational forces. So as humans on Earth, we are subjected to gravity, keeps us on the planet, pretty helpful, but that pull, that constant pull on our bodies definitely has an effect on our structural makeup and pulls us forward, right? So we want to see if that person is submitting to gravity more or less. And you see it more so in our geriatric community as people start to get like that, my mom always called it a dowager's hump, where we see that very prominent forward, chin out. I don't know if so we go from erect to here, right? With the gravitational force of time and weakness, right? Ooh. Okay, let's fix that up again. Posture is considered ideal when the body's mass is evenly distributed around its central axis, which passes through the body's center of gravity. When a client exhibits optimal posture, the postural muscles maintain a state of normal tonus. So we can see here on the bottom of our page with these three pictures, we've created a cross front and back, and then we're looking at a side view of this individual. So we can see with our cross section, his shoulders meet almost exactly in the same spots. It's not 100 or 1000% accurate, because the body is not 100 or 1000% symmetrical, but as much as could be so, right? If we're looking at him from the back though, I would say he has a slight deviation in that right shoulder, bringing it down just a little bit. But when we look from the side view, we see his plumb line is dividing him pretty equally along the axis. When postural balance becomes less than optimal, however, postural muscles must actively contract to redistribute the body mass in relation to the center of gravity and maintain that contraction, putting stress on joints and other connective tissue. Now, I talked a little bit on Tuesday about the body's wonderful ability to compensate. So once you start to pull forward, other muscles are going to have to activate to keep us erect, even though we're not in our optimal postural setting. Postural distortion can result in a wide range of influence, including physical or emotional trauma, poor work habits, pathologic conditions, or age. Through the process of compensation, a deviation in one area of the body can cause a shift in another, an attempt to reestablish overall balance. Compensation usually results in an increased tension of the connective tissue and postural balance, or postural muscle, excuse me. The farther out of balance the body is, the more postural muscles are strained, resulting in increased pain and dysfunction. So the further forward we go, the more they're going to have to hang on. When assessing posture, the therapist notes spinal curves, deviations from the coronal and sagittal planes. We have to remember that way back from chapter 4 or 5. These findings are combined with information from other assessments to identify areas of possible somatic dysfunction. Observing posture gives many indications of musculature imbalance and structural deviation. Many postural discrepancies are due to agonist-antagonist imbalances. So meaning one is activated and the opposite of that muscle cannot activate to compensate for it. So we've contracted here, right, as an example, and these cannot contract to compensate. So we have to train ourselves to have proper posture. And then, since you've been in your incorrect posture for so long, your body fights it, and then you just fall back forward again. It's an uphill battle. So we see down at the bottom of the page here, the very first plumb line we're observing, we see the slight tilt of the pelvis and the body being divided equally with the plumb line. Now, as we look at relaxed posture, we see that their chin protrudes slightly. We get a little bit more of a curvature of the thoracic spine, a more intense curvature of the lordotic spine, but not as intense as if we turned further and looked at the kyphosis lordosis. And then finally we see sway back, right? Where that line is just pertaining to that very back portion, right? Then we see flat back. They have no curvature at all. And then stoop shoulder, which is what I've been pretty much talking about. Guidelines for best observation. Posture is best observed from all 4 sides: anterior, posterior, left lateral, and right lateral. When the client is standing comfortably erect, assess from top to bottom, or bottom to top, noting symmetry of body's bony landmarks, including his ankles, fibular heads, greater trochanter, iliac crest, scapulas, acromoclavicular joints, and ears. Beginning at the feet, notice whether they are evenly angled and placed equal distance from the midline, and whether the arches are supported the ankles. Do the patella point forward? From the back, is the Achilles tendon aligned perpendicular to the floor? Is the pelvis rotated or tilted, either from side to side or front to back? The angle from the posterior iliac spine to the anterior superior iliac spine should be no more than 10 degrees from horizontal for women and 5 degrees for men. If a person has good posture, a plumb line perfectly bisects the body when it is viewed from the front or back. From the side, the line would go through the ear, shoulder, elbow, acetabulum, knee, and just in front of the ankle. Right, so we see that here in that diagram again. By extending the vertical plumb line forward, ideally the pubic symphysis, manubrium, and front of the zygomatic arch would be vertically aligned. When observing a person, notice whether one side of the body is held higher than the other. And this is something that you will just pick up and start doing. You'll be watching people in the grocery store and you'll see shoulders raised or hips raised, or the way that they step, one foot is turned out and the other points forward. It becomes unstoppable. When observing a person, notice whether one side of the body is held higher. Notice hips and shoulders at the AC joints, the hands, the ears, the eyes to check whether they are level and even. Notice any rotation. Is there any rotation in the torso? Is either arm or leg rotated? Is the head rotated or tilted? Assess for relative muscle bulk, symmetric skin folds and scars. Any deviations suggest muscle imbalance or facial constriction. Fascial constriction, excuse me. The farther out of balance the body is, the more strain is placed on the postural muscles. As the body ages, the pull of gravity tends to increase the deviations. When the client lies supine on the table and is comfortable, again, notice any deviations from bilateral symmetry. Observe the contour of the body as well as structural and skeletal symmetry. Is the head tilted or turned? Is one leg rotated to a different angle? Right? Is one foot up and the other rotated out? Are the hips level? Minor postural deviations are caused by muscular imbalance, either by muscle weakness, flaccidity, muscle tension, or both. There is often an agonist-antagonist imbalance in which one muscle is hypertonic and constricted, whereas the opposing muscle is hypotonic and weak. Fascial constrictions or adhesions might be present. Some forms of massage and soft tissue techniques can be very effective for relieving these imbalances. Make note of abnormal marks, discolorations, varicosities, difference in skin texture and scars. Check for skin conditions like redness, areas of increased heat, swelling. That would be signs of infection. Be aware of anything that might be a sign of former trauma or conditions that could indicate or contraindicate massage. Gait assessment. This is something that you'll start doing in Walmart as well. Assessing gait is similar to assessing posture, except the body is in motion. Methods of gait assessment have advanced with the use of computers, video cameras, and sophisticated measuring devices. For the purpose of massage therapy, the monitoring devices are the therapist's eyes. The client's gait should be viewed from the front, back, and both sides to gain as much information as possible. Gait assessment is performed as the client walks in a comfortable, relaxed manner for several paces back and forth in front of the therapist. When a person is walking, the steps should be even and smooth, with the heel of one foot making contact with the floor as the weight of the other foot transfers smoothly to the ball of the foot. The movement of the legs is in the direction of the line of motion, with the knees and feet pointing in that direction. The steps are smooth and even. The torso is well balanced above the body's center of gravity, and the pelvis shifts slightly with each step. The arms swing easily on opposite sides, opposite of the legs. And as the right foot moves forward, the left arm swings forward and vice versa. The hands are relaxed, the thumb forward, and the hands swing straight forward and back. The head is balanced on top of the spine. the motion is fluid and smooth. Most of these things you will be able to pick out fairly quickly. There are other considerations to observe. Is the gait initiated without undue pelvic tilt? Do the feet clear the ground with each step? Is there drag on one of the feet that they can't actually get a full step? Right, some of these things will jump out and be more observable. Other people might have more minute deviations. Is the gait initiated without undue pelvic tilt? Do the feet clear the ground with each step? Does the foot strike the ground in a heel to toe fashion? Is the length step symmetric? Is the width of the stride symmetric? Is there a straight alignment of the hip, knee, ankle through the entire stride cycle? Is there ample extension in the hip to allow the step to roll off the ball of the foot and toe? When assessing gait, the therapist should note any asymmetry, crossover, or rotation of the feet, arms, or any restrictions of free movement. Is there any pain anywhere? The information gained during gait assessment can indicate body structures that are constricted. This information combined with findings from other assessments to help determine areas of the body which to focus and determine which interventions to be used. So this is all in helping you decide how you're going to proceed with the massage. On this page here, page 666, I want to define a couple terms. I want you to highlight these purple boxes here. So range of motion, or ROM, is the movement of a joint from one extreme of the articulation to the other, right? So this is my elbows, range of motion, right? Contractile tissues are the fibrous tissues that have tensions placed on them during muscular contractions. Inert tissues are the tissues that are not contractile, such as bone, ligament, or nerves. End feel is the change in the quality of the movement as the end of the movement is achieved. Capsular pattern refers to the proportional limitation of any joint that is controlled by muscular contractions. So observation is also important in tests such as range of motion to notice any restrictions in joint mobility and the quality of movement and the client's reactions to the test. Range of motion is the action of the joint through the entire extent of its movement. Assessing the extent and quality of that movement by testing the active and passive and resisted or isometric movement provides information about the tissues associated with the joint. Normal range of motion may be restricted by tension or injury associated with muscles, fascial constriction, degeneration of the joint, inflammation of the bursa, or other pathologies. Contraindications for range of motion in assessment include acute osteoarthritis, gout, and acute strains or sprains. Testing of range of motion. Dr. James Cyriax, an osteopath from England, developed an extensive system of testing all the joints to isolate lesions in hard and soft tissues. Cyriax clarified and defined terms and concepts that are invaluable when assessing the range of motion. Those concepts include contractile tissue, inert tissue, end feel, and capsular patterns. And we just discussed those over here. When assessing range of motion, the good or unaffected side is tested first to help determine that person's normal. First, active movements are tested, then passive, and finally resistive movements. When testing, observe and record objective and subjective findings. Objective findings are what the therapist sees or feels, such as muscle strength and degree of joint movement. Subjective findings, including the amount of pain or discomfort the client feels, how the client reacts to pain. Objective findings generally can be measured, where subjective findings are usually felt or perceived. Go ahead and highlight here. Assessing active range of motion gauges the client's ability and willingness to move a body part through a range of motion that is normal for the joint. And highlight. The client is instructed to move through a particular range of motion. The client makes the move totally unassisted. If the entire movement can be made smoothly and painlessly, there's probably no problem with that joint or the associated soft tissue. Both contractile and inert tissues are involved during assessing active range of motion. So if there's any obvious limitation, pain, or hesitation during movement, a closer assessment is needed. If there was any pain during the movement, the therapist should know at which point in the movement the pain occurred, the location of the pain in the client's body, intensity and quality of the pain, and the client's reaction. If there is a limitation to the movement, note where the limitation occurred and whether it was accompanied by pain. Using a subjective analog pain scale, where the client rates the pain scale from 1 to 10, is an effective way to document intensity of pain. Assess passive range of motion. When assessing passive range of motion, the practitioner moves the client's joint through full range of motion. That is normal for the joint while the client remains relaxed. So you are doing the work here. During PROM, the practitioner determines the degree and quality of movement in a joint. The practitioner can sense whether the joint is hypermobile or hypomobile. The therapist can also note any catches, crepitus, or pain during the movements. The reaction of the client must also be observed. Any apprehension or unwillingness must be considered and respected. So as you are moving them through their range of motion, if they get to a point where they feel uncomfortable, like if they were moving it, they would, okay, I stop here, and then you were moving it and you get to that point and they say, and that's where it starts to feel painful. You need to respect that and not pull them past something that you can physically move them through, even though they can't physically move themselves through there. End feel. End feel plays an important part in assessing passive movement. End feel is the feeling that the therapist senses by passively moving the limb to the limit of its range of motion and applying slight overpressure to determine the quality of end feel. The quality of end feel indicates the presence, type, and severity of lesion in the tissues associated with the joint. So let's go ahead and highlight here. There are 3 types of end feel. End feel are considered normal. We have hard, soft, and springy. Hard end is bone against bone feeling. We're highlighting. This is an abrupt, painless limitation to further movement. That happens at the normal end of the range of motion, such as the knee or elbow extension. I'm meeting bone to bone here. I'm not hurting myself going in further, right? Because I can't go any further. Highlight number 2, soft end feel is a painless, cushioned limitation in which soft tissue prevents further movement, such as knee or elbow flexion. So we get here and I can move it a little further, right? But I've got structures in the way, such as the rest of my arm. Then number 3, go ahead and highlight. We have springing end feel, or firm end feel is most common. Limitation is caused by stretch of fibrous tissue as the joint reaches the extent of its range of motion, such as hip flexion or extension. My computer doesn't allow for me to demonstrate that for you because it's too tall. Normal end feel happens when the range of motion is stopped by the anatomy of a joint unless carried to extremes, is painless. Pain or an observable limitation of the movement indicates that some abnormal condition or lesion is present. If pain occurs before reaching the end movement, there is no muscular resistance or spasm, bursitis, capsulitis might be the cause. If the movement causes sudden painful muscle reaction or spasm, the body might be protecting an injury in the area. Cyriax calls this an empty end feel. This is more acute and severe the injury is, the more severe the pain and spasm. A medical referral and diagnosis should be recommended in these cases. Other abnormal end feel patterns are similar to normal end feel, except for reduced range of motion and or associated pain. There are 5 types 5 abnormal types of end feel. So let's highlight numbers 1 through 5. Bone to bone is hard, abrupt stop to movement when bone contacts bone. Pain or restriction might occur sooner in the range of motion than a typical hard end feel. This may indicate degenerative joint disease, dislocation, or fracture. Firm occurs sooner than the range of motion than usual, or in a joint that is normally has a soft or hard end feel, indicating increased muscle tone or soft tissue shortening. Muscle spasm is a sudden stop to passive movement that is often accompanied by pain. It indicates an acute or subacute arthritis, the presence of a severe lesion or fracture. Empty end feel involves considerable pain of normal end before the normal end of the normal range of motion and indicates some pathology or injury. And springy block is seen or felt as a rebound, indicating the presence of internal derangement such as torn meniscus. PROM assessment indicates the condition of inert non-contractile tissues. Limitation to the movement and pain indicate dysfunction. Full painless range of motion indicates that the joint and associated structures are healthy. Reduced range of motion that is limited with a painless hard end bone-to-bone feel indicates osteoarthritis. Pain and limitation in all degenerations generally involve the whole joint and indicate capsulitis or arthritis. Pain or limitation in one direction and not the other usually caused by stretching or compressing the involved tissue. More specific assessment must be performed to isolate the involved tissue. Assisted resisted range of motion. Resisted range of motion assesses the relative strength of muscles. Resisted or isometric movement is used to assess the condition of contractile tissues. This method is also known as muscle testing. Weakness and pain indicate lesions in the contractile tissue. To perform resisted range of motion assessment or muscle testing, the therapist stabilizes a body part in a neutral position near the mid-range of the joint and instructs the client to move the body part in a specific direction. As the client contracts the muscle required to move the direction, the therapist applies pressure to move the body part in the opposite direction. So pushing this way, you resist. Eliminating any joint movement minimizes reaction of the inert tissues and indicates the relative strength and condition of the targeted contractile tissues. Positioning the body part and instructing the client to make a specific movement isolates specific muscles to be tested. When contractile tissues are involved, active movement and resisted movement both give positive results. In other words, when the target muscle is activated, there is notable response in its pain. Passive movement shows nothing except the end of the movement, whereas contractile tissue is stretched and which then reacts with pain or spasm. Muscle testing, or ROM, provides information about the condition of the muscles involved in a specific movement. As with other physical assessment tools, it is important to compare one side of the body with the other. So we need to see what normal is, and we need to see what the deviation or dysfunction side is. And we say normal because it's normal to that person. Test the good side first for comparison. A muscle that is strong and pain-free indicates healthy muscle tissue. A strong and painful muscle test indicates a lesion in the contractile tissue, such as a minor first or second degree muscle strain. A weak, painless muscle test indicates interference with the nerve supply or circulation to the muscle. No strength in the muscle could be caused by severe muscle or tendon, third-degree strain, or loss of innervation. A very weak and painful muscle test indicates severe lesion, possibly torn ligament or fracture that should be referred to a doctor. In general, the more severe the condition, the more severe the pain. Other orthopedic tests. There are other special orthopedic tests and assessments that isolate certain structures and provoke specific symptoms to identify conditions or pathologies that a client might be experiencing. These assessments are often named according to the area of the body being tested after the person who devised the test. Addison's test, Phelan's test, Ober's test. There are orthopedic tests for most body structures, but discussion of these tests is beyond the scope of this text. Students interested in clinical and orthopedic massage skills are encouraged to seek and study continuing education. All right, so recognizing soft tissue barriers. When assessing and treating soft tissue conditions, the therapist must recognize soft tissue barriers. These barriers represent the limits within the tissues that can be effectively manipulated. In developing sensitivity to soft tissue barriers, the therapist can better adjust the amount of pressure used to generate a therapeutic response from the tissues. Soft tissue barriers come under consideration when compressing tissues, stretching the tissues, and mobilizing joints. For instance, when a therapist is passively moving a healthy limb through its normal range of motion, the limb moves freely without any resistance through the middle of the range. The freely flexible range of motion refers to the pliable and easily movable range of the tissue. As the end of the range is approached, the therapist will notice the slightest resistance as the slack is taken out of the tissue as they begin to stretch. This is the beginning of the resistive barrier. The client might or might not sense the beginning of the resistive barrier. As the stretch is continued toward the end of the movement, more force is necessary until the tissues are stretched and the client feels like that is about as far as it goes, which represents the physiologic barrier. With more force but possible discomfort to the client, the anatomical barrier is approached, at which the tissues would be maximally stretched. Going farther might damage the tissues. Right, and so they created a diagram here in figure 1710 to kind of demonstrate how those barriers stack up. Detecting dysfunction. Soft tissue barriers vary according to the condition of the tissues. In healthy tissues, for instance, free and relatively painless movement can continue easily well into the physiological barrier and approach the anatomic barrier before any resistance is encountered. In damaged tissue or tissues that house latent or active trigger points, scar tissue, and other injuries, resistive and physiologic barriers might be encountered early in the movement. Massage considerations for soft tissue barriers. Barriers are also taken, into consideration when performing compression and fascial stretching manipulations. When using ischemic compression over a trigger point, first contact the nodule might be considered the resistive barrier. The client might realize that you're on a tender spot, but there's no discomfort. As the pressure is increased, the physiologic barrier is approached, and the client might express a response of discomfort, often accompanied by pain in referral areas. Let's go ahead and highlight here. The anatomic barrier should never be approached or passed because doing so could damage tissues, injure the motor end plates, bruise the tissue, and possibly activate latent trigger points. End highlight. As the tissue is moved and manipulated through its range of motion, 3 types of barriers can be considered. 1, the resistive barrier or pathologic barrier is the first sign of resistance to a movement and is important when assessing and treating soft tissue conditions. The physiologic barrier represents the extent of easy movement allowed during the passive or active movements. And let's highlight here. The physiologic barrier is within the anatomic barrier. Now we see that demonstrated up in that diagram and represents comfortable end tissue stretch at the end of range of motion. The anatomic barrier refers to the anatomic limit of motion in a particular tissue. To move beyond the anatomic barrier would injure and disrupt tissues and supportive structures. So we see those being demonstrated within these 3 pictures at the top of the next page. Physiologic and resistive barriers are well within the anatomic limits of movement of involved tissues. Approaching barriers that are normally restricted or painful, that are within normal range of motion, might reflect pathological conditions in the tissues. So if it is within the range of motion and you can comfortably move the client there, is how you can kind of detect what sort of dysfunction or abnormality is taking place. Resistive and physiologic barriers reflect conditions of bind and ease related to contractile tissue and fascia. When healthy tissue is manipulated or moved through its possible range, an ease of movement is sensed throughout the movement. As the tissue approaches the outer limit of possible movement, the first sense of bind is felt. The first encounter of bind represents contact with the resistive barrier in that direction. By using incrementally more force, movement can continue through the resistive barrier into increased bind and resistance until the physiologic barrier is encountered. When contractile tissue is constricted or injured, the physiologic barrier is encountered before the normal range of motion and well before the anatomic barrier. If more force were applied, movement could continue through the physiologic barrier into more bind until the anatomic barrier is approached. Movement beyond the physiological barrier usually causes excessive discomfort and possibly more trauma and results in tissue damage. So we don't want to force them through if there's already damage there, because we're going to be doing more damage on top of old damage. When addressing soft tissue conditions with less than healthy tissues, the amount of force used to approach barriers varies greatly and requires a developed sensitivity on the part of the therapist. The therapist's response is achieved by applying force that elicits response between the resistive and physiologic barriers. So developing palpation skills. Many forms of bodywork disciplines require skills sensed through touch, the conditions and subtle changes that take place in the body's tissue. Acupuncture diagnosis reads the subtle differences in deep and superficial pulses and palpates the exact location of the acupuncture points. Acupressure, shiatsu, jinshin do, and other touch modalities derived from Asian model depend on a sense of touch to identify points in the body and monitor subtle changes. Monitor subtle changes in those points as they are traded. Craniosacral therapists monitor cranial rhythms and other subtle changes in the tissue as they palpate and treat body structures. And myofascial release, fascial preference, and change are monitored through palpation. The sense of touch is one of the massage therapist's most powerful tools. It is what puts the therapist in close contact with the client. It is a means of communication between the therapist and the client's body. Developing palpation skills, sensing the difference in tissue quality and integrity, responding with the appropriate therapy techniques are marks of a good therapist. Palpation is a skill and art developed by a therapist to locate various body structures. It is also the primary assessment tool allowing therapists to listen to the client's body through the therapist's hand. The way I like to explain it to my clients is when I'm doing massage, most of the time, aside from, examining their facial expressions to make sure that we're not going anywhere that's painful, I close my eyes and I feel as almost as if my fingers have eyes and I am analyzing the structures I'm touching and feeling the difference in the textures between the skin to the muscle and down into the deeper structures beneath those muscles. Learning to see with your hands the way muscles and soft tissues feel takes practice. And you only learn if you get your hands on hundreds of bodies. The successful massage therapist develops skills to differentiate between the feel of normal and abnormal soft tissue. By palpation, the therapist should be able to identify bony structures, skeletal alignment, individual muscles, and various conditions of soft tissue, such as tight or loose conditions, tenderness, adhesion, constrictions, spasms, fibrosis, top bands, and nodule or trigger points within the muscle. And as you practice, as you go through your career, you'll be able to learn how to feel these different things. Palpation is used during preliminary assessment to identify and localize areas of concern. It is also used extensively during treatment to identify target tissues and monitor changes continuously in soft tissues as the session progresses. The hands are the main vehicles to deliver manipulations to soft tissue. At the same time, the hands carefully monitor underlying tissues for changes in response to manipulations. So as you are performing manipulations, you are also analyzing what is happening with those manipulations. Let's go ahead and highlight here. Although many massage therapists use palpation as the primary form of assessment, it is most accurate when used in conjunction with and after range of motion and orthopedic assessment skills. And highlight, especially in pain conditions where there is radiating or referred pain, observation and examination can isolate the cause of the pain, and then palpation pinpoints the source. As with other assessment techniques, the therapist should make bilateral comparisons. You're always feeling the good side and then feeling the deviated side. Although many conditions affect both sides of the body, bilateral comparison helps establish what is normal for that person and to determine whether the tissue in question is involved in the dysfunctional condition. Assessment by palpation is both objective and subjective. As the therapist's hands palpate the body's tissue, the therapist must pay close attention not only to the quality of the tissue, but also to the reactions of the client. The therapist begins lightly and proceeds to probe deeper into the tissues, noting any signs of tension, lesions, or pain. Depth. Assessment using palpation can be done at many levels, from superficial to deep. The most superficial level is just above the body, not quite touching the skin. Variations in temperature can be sensed. Warm areas can indicate increased activity or inflammation. Cooler areas can indicate congestion or reduced circulation. A subtle energy field can also be sensed at this level as a slight pressure against the palm of hand, possibly indicating high active area, or an empty feeling, indicating a depleted condition. The next level of palpation is the surface of the skin. The temperature, texture, color, moistness in the skin are noted. Increased temperature or surface moisture indicates conditions in deeper tissues. Remember, inflammation is local contraindication for massage. The signs of inflammation are heat, redness, pain, and swelling. Palpation can detect abnormal sensations that the client might be experiencing, such as a lack of sensation or increased or diminished sensation. The quality of subcutaneous tissue or superficial fascia is the next level to assess. So we're going down through the tissues. We were above, we went in, now we're deeper into the tissue still. The superficial fascia connects the skin to the underlying muscle and other tissues, yet at the same time, it allows independent movement between them. Highlight, skin rolling is an important part of layer palpation. It gives the clinician information about the extensibility of subcutaneous connective tissue. And highlight, in skin rolling, the skin and the superficial connective tissue are lifted up, away from deeper tissues. You see this demonstrated here in the corner of the page. The extensibility of the tissues, as well as their integrity, can be palpated. A slight compression with the palm side of the fingers or hand should give the sense of springy cushion between the skin and deeper tissue. The skin should also glide over the underlying tissues in short distance in every direction. So what they mean is, if you had restriction in the movement where we couldn't move this skin and it was completely taut and did not move, right? We would feel restriction there. That's what they're trying to convey. Although it tends to move more freely in one direction than any others, Fascia that is tight or stuck might indicate a deeper dysfunction. The superficial fascia is also a site of superficial lymph nodes and blood vessels. The blood pulse can be felt by palpating superficial arteries. Lymph nodes feel like small nodules between the size of the small pea and a kidney bean. They can also often be palpated along the side of the neck, in the axillary area, or along the inguinal area. Enlarged lymph nodes should be brought to the attention of your client and the client referred to the doctor so the cause can be properly diagnosed. Skeletal muscles and related structures. The next level of palpation is to skeletal muscles and the related structures, textures and structures. Deep palpatory examination includes compression into the tissue and shearing force along or across the tissue. Compression is palpation through layers of tissue perpendicular to the surface tissue. Shear is the movement of tissue between layers, moving parallel to the tissue. Muscle is composed of contractile fibers that are organized and held in place by layers of connective tissue to form distinctive patterns that can be easily palpated. When palpating muscles, the therapist observes tissue consistency and texture. In a relaxed state, muscle tissue is somewhat pliable and evenly grained, with the fiber orientation easily identified. Normal qualities when palpating over muscle would allow the following: moderate movement of skin and subcutaneous tissue over the muscle in all directions, an even smooth grain when moving across the muscle fibers, and soft, yielding, painless firmness when pressing into the muscle. That's the texture that they're trying to explain. Abnormal qualities include restriction in the movement of the skin over the muscle sheaths, underlying structures, ropey or fibrous muscle tissue, tense or spasm muscle tissue that is painful to the touch, or hypersensitive nodules that are painful when compressed. Constricted muscles feel denser or tighter, more restricted, more fibrous, and less pliable. A common palpable condition is found in muscle that is usually associated with the lesion is fibrous or taut band. Taut bands usually run the length of the muscle and feel like hardened, fibrous bundle that you can actually pluck. Taut bands are usually associated with a previous injury, a strained muscle, or habitually overstressed area. Lots of times you'll find taut bands up through here, and they'll just like harp strings, fring, fring. Often taut band harbors one or more hypersensitive points that can be latent or active trigger points. Let's go ahead and highlight finding and reducing taut bands and trigger points are among the most effective ways of treating soft tissue pain and dysfunction. Toward the end of the muscle, the connective tissue that separates and organizes muscle fibers continues beyond the ends of the muscle fibers and becomes the muscle attachments that form rope-like tendons and wider tendon sheets. This area is known as the musculotendinous junction, right? Musculotendinous junction. We can use our medical terminology to determine exactly where that is in the body. Then we also have the tendinoperiosteal junction, where some tendons can be noticed if the muscle is under extensive stress. Palpating bony landmarks. The massage therapist palpates bones as landmarks to identify muscle attachments. So if you know what bone you're palpating and you know what muscles attach to that bone, you'll be able to discern, once you found a bony landmark, what musculature you're affecting. Palpating joints and related ligaments. The next level to be palpated is the joints and the related ligaments. A joint is where two bones join together. Highlight. Ligaments are tough, somewhat flexible connective tissue that connects the bone at the joints. And highlight. Ligaments are also slightly elastic and just flexible enough to allow an appropriate amount of movement. At the same time, they are resilient enough to stabilize the joint. Excessive play in the joint or painful response when palpating a ligament usually indicates dysfunction. Joints are usually, highlight this, joints are usually palpated during active or passive joint movements. And highlight, The quality of movement is assessed, noting smooth, unrestricted, and painless movement through the range of motion. The end feel as the joint approaches the end of the range is also noted. All right, let's move on down to the opposite page, 675 at the bottom. Differentiate between acute and chronic conditions. Acute and chronic are terms to describe a condition, pain, or illness. Highlight. Acute refers to a condition with a sudden onset and relatively short duration. Chronic refers to a lingering or ongoing condition. And highlight. Acute pain is sharp, the symptom of an identifiable incident or illness, or warning to take action, but is usually temporary. Chronic pain is persistent or intermittent over a long period, often dull, diffused, and many times has no identifiable cause or source. An acute illness has a rapid onset and is relatively short-lived. A chronic illness progresses slowly and is difficult or impossible to remedy and can last weeks, months, years, or even be lifelong. Acute soft tissue injury. Acute injury is usually due to trauma or abuse, resulting in damage to hard or soft tissue. When soft tissue is injured, whether at a cellular level or if there is a gross tissue damage, a natural process of healing and repair takes place. The process, known as inflammatory response, is fairly predictable, when the focus being repair and reorganization of damaged tissue. The stages of inflammation include acute and subacute phases, including the regenerative and remodeling phases. Let's turn the page and highlight the first sentence. When tissue is injured, histamines are released that cause local vasodilation and increased vasopermeability, resulting in swelling, heat, and increased tenderness to the injury site. That's pretty standard for any sort of trauma. We see inflammation. Right. During this early phase, local and systemic activity involves many biologic processes that are working to reestablish homeostasis. The body wants to always get back to that baseline. Locally, the tissues are flooded with interstitial fluid as dead and damaged tissue is carried away, while fibroblasts begin to lay down a random network of fibrin to secure tissue damaged tissue. All right, so fibroblasts, we see the blast word in there. That means they're building. During this initial period, which lasts anywhere from a matter of hours to a week, depending on the nature of the injury and the condition of the client, any treatment that might disrupt these delicate fibrin structures, including massage, is contraindicated. During this time, proper treatment include protecting the area, rest, ice, compression, and elevation, otherwise known as price. An important benefit of price is that it reduces some of the swelling to otherwise injured tissue. Another advantage is that pain is greatly reduced. Lymph massage proximal to the injury site further helps reduce the swelling. So then we have the regenerative phase. During the regenerative phase, fibroblasts generate collagen fibers that randomly create bridges to bind tissues together, thereby not only scarring the damaged tissue, but also binds tissues together, thereby creating not only scarring of damaged tissue, but also fibrous cross-linking between fascial sheaths. Stability of the tissue improves. However, if left unchecked, cross-linking in the fascia and scarring can negatively affect functionality because it doesn't have the same mobility as the structure that was once there. At this stage, tissues are very delicate, but gentle techniques can be employed that encourage alignment of the collagen network to restore stability as well as function. Techniques include mild tensioning or lengthening with passive pain-free range of motion and light cross-fiber manipulations. Non-weight-bearing active range of motion helps restore mobility and produce strong, pliable scar tissue. Techniques are applied to the surrounding tissues to help reduce spasm and splinting and to promote circulation, reducing ischemia and encourage drainage. The remodeling phase. Collagen production and cross-linking continue during the remodeling phase. Tensile strength of the tissue increases. However, pliability and functionality can be reduced because of the scarring and collagen cross-hatchings that effectively glue the involved layers of fascia together. Manipulations that slowly and deliberately lengthen the tissue, the injured tissue, to its full functional length, such as pain-free range of motion, muscle energy techniques, and gentle stretching exercises help reduce fibrosis and restore tissue full functionality. Gentle yet cross-fiber massage helps reduce and prevent cross-linking and aligns fibrous connective tissue to form functional scar tissue. So if you do not work with that scar tissue to help restructure it, its movement is going to be severely reduced. As flexibility is restored, gentle exercises can be initiated to help the client regain strength and tone in the tissues. Treatment for injuries. Treatment strategies, let's highlight here, for acute and chronic conditions are very different. Right? We're not going to treat an acute injury the same way we treat chronic injuries. Most acute conditions and injuries are contraindications for most forms of massage and body works. Acute illnesses are often accompanied by fever and also contraindicated massage. Acute injury with tissue disruption is a contraindication for massage until tissues have stabilized and infiltration and swelling have subsided. In the subacute stage of soft tissue injury, gentle lengthening and gentle cross-fiber techniques can be employed. The sessions are rather short, quite frequent, sometimes daily or even twice a day. Sessions for more chronic conditions are usually longer in duration and not as frequent. So use assessment information to plan your sessions. So within the massage session, you need to plan your plan of action. So we have goal setting. Part of developing a treatment plan is establishing goals. This sets a goal in mind for you and the client. You two are both aware of it. Goals must be realistic and attainable. The client's concerns and needs and the assessment findings are considered when setting goals. Session strategies and therapeutic interventions are then chosen to work towards those goals. After those strategies have been implemented, evaluation of the session helps determine whether those goals have been met or whether the treatment plan should be modified to achieve goals in future sessions. So we decide on our plan of action, we use our plan of action, and then after the session, we decide whether that was the correct course of action. Right, components of a treatment plan. Depending on the assessment findings and chosen goals, the treatment plan can include the following: referral to another healthcare professional for further assessment, referral to another health professional for treatment in lieu of or in conjunction with massage, the initial number and frequency of sessions to be given, the estimated length of treatments and whether they are full body or specific to the condition, the use of modalities such as heat, ice, or hydrotherapy, which massage techniques will be used and avoided, areas of the body to be addressed or avoided, recommendations for home self-care, and which results are expected and by when. Treatment plan discussions. Accurate assessment allows the therapist to design treatments with modalities, massage techniques, and regimes that best fit the client. Modalities and techniques used depend on the skill and knowledge of the therapist and techniques for which the therapist is qualified to be able to perform. The assessment findings and treatment plan are discussed with the client so he or she actively involved in the process. Clients who actively participate in therapy generally reap more benefits. If your client does not want to play, they will not receive as much benefit as someone who is willing to go home and do the homework. I think that goes with anything. Discussing the assessment findings with the client also teaches them about the function of the body and the nature of the condition so they can make educated choices about which changes to make to help correct the cause of the condition. So We're constantly showing them, teaching them, educating them about their own body. Knowledge of therapy strategies gives the client a clear idea of what therapy will consist of and what to expect during the sessions. Go ahead and highlight here. The treatment plan goal is to inform the client what will happen during the session so the client can be more relaxed and receptive to the treatment. I don't know about you, but if I don't know what's going on, I'm a little on edge. So by explaining the treatment plan to them, they know what's going to come next, why they're doing it, and the intended goal of whatever you're doing. When discussing assessment, findings, and treatment plans, use terminology that clients can understand. Yes, we want to be able to speak with our medical terminology, but some of our clients may not understand it, and we don't want our clients to feel stupid. We want them to feel empowered to take part in their wellness. So we need to use terminology that they're understanding. Let's see. Let's pop over to massage therapy for soft tissue dysfunction on page 679, excuse me. Musculoskeletal dysfunction is often characterized by postural deviation or movement restriction and is often accompanied by pain. The cause: constrictions in soft tissue result from overuse, underuse, misuse, abuse, or trauma to the body. Soft tissue related pain, myofascial pain, muscle pain or spasm, and ischemia all respond well to soft tissue interventions and therapeutic massage techniques. Tension, restricted movement, asymmetry, localized or referred pain, and stress are also indications for therapeutic massage. The intent, let's highlight here. The intentions of soft tissue interventions are the following. They are to reduce pain, restore circulation, oxygenating tissue, releasing trigger points, fascial restrictions and adhesions, improving functional range of motion, integrating restored area back to a whole, ultimately increasing quality of life. Then we have our rehabilitative process. To restore muscles successfully to a healthier state when the area of the body has experienced dysfunction, pain, trauma, or compensation requires proper rehabilitative steps to ensure longer lasting recovery. Highlight: after careful assessment to determine which tissues are involved and that there are no contraindications to treatment, take the following steps. Highlight: step 1, restore circulation and neuromuscular response to the tissue. Step 2, release any trigger points and fascial restrictions in the muscle tissue and restore flexibility. Step 3, rebuild muscle strength and endurance, and that's going to come with them doing their homework. And highlight: the first steps can be accomplished in the treatment room. Strength and endurance include self-care plan that are done through exercise. Be sure to remain within the scope of your practice for your state when it comes to stretching and exercise. It is also important as far as possible, identify and try to remove causative factors that initiate the dysfunction. In the case of acute single onset conditions, this is fairly simple. In the case of chronic conditions, however, isolating causative factors is more difficult. It might be their job that's causing it. So it's, you can't just be like, hey, quit your job. This is what's causing the problem. So they're going to need to make adjustments at work so that they don't continue doing these detrimental activities. All right, let's talk about postural versus phasic muscles. Skeletal muscles can be organized into two groups according to function, fiber type and reaction to stress. Skeletal muscles, let's highlight, are composed of two types of muscle fibers, type 1, which are slow twitch, and type 2, which are fast twitch. And these were talked about in the muscular portion of chapter 5. Keep highlighting, most muscles contain both types of fibers. And your highlight, the portion of slow and fast twitch fibers depends on the primary function of the muscle. So, postural muscles and phasic muscles, we've talked about these back in chapter 5. Postural muscles primarily maintain upright posture, require endurance, and have a higher proportion of slow twitch muscle fibers because they're doing that slow contraction, keeping us upright, our posture. It's right there in the name. Phasic muscles are the movers of the body and respond quickly and forcefully when stimulated. Phasic muscles contain higher proportion of type 2 fast twitch fibers that react quickly but also fatigue quickly. So they can react quickly, but they don't have the ability to maintain that strong postural contraction because they are phasic muscles. So next, let's talk about hypertonic and hypotonic muscles. Common structural, body, and postural imbalances generally involve muscles or groups of muscles that are constricted or hypertonic. That is, they seem tight or result in postural deviation or constriction in joint movement, or both. Constricted tissues could be the result of hypertonic musculature. Highlight that whole bit there. Or in the case of chronic conditions, constrictions or fibrosis in the fascia supporting the muscles. Right, so examining involved tissues with range of motion and palpation can reveal which tissues are involved. When examining and treating an area of the body, look beyond specific site and include associated muscles in treatment. It's not going to be where you just look at one single muscle, right? There's going to be Smokey and the Bandits. There's going to be a group of guys that are working together to perform this dysfunction, either with hypertonicity or hypotonicity. When a weak muscle is found, often the opposing muscle or possibly the synergistic muscles are found to be overactive, tight, or hypertonic. In these circumstances, releasing hypertonic or constricted tissues is often the primary focus. However, stimulating and stretching the hypotonic antagonist is also a major consideration in a treatment plan. If the target constricted muscle contains trigger points, it is important to relieve those and encourage the muscle to reestablish a normal resting length. At the same time, stimulating and strengthening the antagonist has the inhibitory and balancing effect on its hypertonic partner, because they work in pairs, guys. The overall result is a more balanced structure. Let's turn to page 682. And I want you to look at the table we have there. Effective techniques to address soft tissue conditions. I want you to come about 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 subjects down. We see deep gliding or stripping. It assesses superficial tissue and deeper tissue quality, increases local circulation, softens connective tissue, and separates adhesions. Right? That's what you're going to be using in your neuromuscular techniques. Right? Let's turn the page. So let's look at this final review, the outcome of the session. Post-session evaluation. So you want to see what you have done. Did it do anything? Post-session evaluation involves examining the outcome of the therapy in relation to the expected goals and objectives. Evaluation is important because the client and therapist can gauge effectiveness of the selective course of therapy according to the success in attaining the goals. Did the course of action that I chose help this client? Yes, no, kind of. We sort of got there. We need to get some feedback from the client. We need to examine what the client's movement is. We need to gauge their pain level now. Evaluation is important because the client and the therapist can gauge effectiveness of the selective course therapy according to the success in attaining the goals. Examining the outcome is important when deciding ongoing therapy. Do we need to continue this therapy because we did see some results? Or did we not see any results and we need to change our course of action, right? And it provides a rationale for applying similar therapies for similar conditions in the future. So Not that any two people are the same, but you will start to see patterns in musculature on different people that are experiencing the same kind of dysfunction. Evaluation also identifies grounds for altering parts of the process to effectively achieve desired results. Finally, evaluation helps determine whether goals have been met and whether a referral to another professional is warranted. Evaluation is both subjective and objective. Much of the evaluation is based on how the client feels as a result of the therapy. Levels of posture, mobility, pain, and function can be reassessed to indicate the success of the treatment. Evaluation is performed at various times during the therapeutic process. After such an assessment, a decision is made regarding how or whether to proceed. Evaluation occurs after a single session and during the performance of a session to determine the effectiveness of chosen modalities and techniques. The evaluation can identify changes in mobility or pain levels and whether the goal for the sessions have been met. If the decision is made to continue with several sessions, highlight here, evaluations after each session help plan future massage therapy sessions, right? So we use the plan that we have used that session to cater the next sessions, right, in succession. A lot of succession there, sorry. The evaluation can carry over to the beginning of the following massage session to note more long-term improvements and effects of the chosen treatment and make adjustments to any follow-up sessions. So we can get an initial assessment right after the therapy is done, and we can continue that assessment the next time that they come in to see what those long-term effects are, right? We don't have to follow them around with a notepad for the next 2 weeks and be like, okay, what's happening now, right? They come back in and we have them kind of document their process further. So we made it through chapter 17. Does anybody have any questions? It's a lot of info, I will say, but it is very important info.
No questions, but I do have a question about.
Hold on, let me turn my speakers down real low.
Okay.
All right, there we go. There we go.
Okay, so I do have a question about how do I turn in the assignments? Like, how do I email like the assignments to you guys, or do I have to, or?
Which assignments?
All of them.
Well, some things are completed on MindTap. So like if you complete the section quiz, it goes directly into our MindTap gradebook. But if you see something on like the email that you get that kind of give you a breakdown, if it says like review questions or a Beck packet, right? Those need to be either filled out in a PDF and sent back to us to massagetl@sunstate.edu, or you can print them out and write directly on them and then take pictures of them and send those in an email. Or if you don't have a printer, you can pull them up on your computer and then just answer, you know, number 1, label the section, and say it's fill in the blank. So you would write number 1, answer here, whatever the answers are, and then take pictures of that as well.
All right, thank you. That answers my question.
Okay, good. So yeah, just whichever way you can get it to us. We don't care if it's handwritten, just as long as you are going through the information.
All right, cool.
And by the skin of our teeth. All right, so I will see you guys back on Tuesday. I forget what we're going into next, but it will be open on Monday. You'll have that available. And I guess that's it. All right, guys, we'll see you next time.